Lenny, can you please mute yourself? I hope you can see the PPT.
Yeah, I can.
Yeah, so today our section is the 10th one, where we will be dealing with viral diseases, the commonly seen viral diseases, and how it has to be prevented, how it is transmitted, the communicability, how it has to be prevented. So these are the conditions we'll be dealing: common cold, measles, smallpox, chickenpox, polio, infective hepatitis, helminthic infections, enteric fever, dysentery, and animal diseases transmissible to man. Uh, One second. So, when you see the PPT, I mean the slides number, it seems to be too much like 83 because we have this much condition. But individually, in each disease, I have not gone much into its pathophysiology, because all of these conditions you might have started learning this even in microbiology, virology, and later in practice of medicine I myself have taken for you. So the pathophysiology part, I have not gone into depth, and for this subject as of you don't need that much pathophysiology also. More will be like the etiology, the transmission, the communicability, and how to prevent it, and a little bit about the clinical features. That's what you need to know only. So the objective is mainly to study about the viral disease, their transmission, and methods to prevent them. So starting with common cold, which is very common, and that is a viral infectious disease affecting the upper respiratory tract. And it mainly affects the respiratory mucosa of nose, throat, sinus, and larynx. Etiological factors, like almost 200 virus strains are there which can cause common cold, but the most important ones will be human coronaviruses. And this one, while I was putting the PPT, I just realized when I was studying doing BHMS, this coronaviruses were never being put as an etiology, but it's after to COVID that it came. It took the pioneer place itself in common cold. uh, yeah, I just told that it never used to come in our list also. It was mainly influenza, RSV or respiratory syncytial virus, rhinovirus, adenovirus, and enteroviruses, which we used to specify. But for you, yeah, after to COVID, it's coronavirus also, and that is taking the first position. Mode of transmission, it is by droplets. And also it can be via the direct contact, especially if we are going to touch the things used by the patient, the fomites, or a close association with that person where we are coming into contact with his nasopharyngeal secretions. That can also result in the transmission. Incubation period is very short, from few hours to 2 days after to exposure. And clinical features will be almost the URTI symptoms, upper respiratory tract. There will be cough, but it won't be much productive because the lower respiratory tract is not involved. So it will be dry cough also. Then runny nose, sneezing. One second. Runny nose, sneezing, nasal congestion, a sore throat, and sometimes may be associated with muscle ache, fatigue, headache, and loss of appetite. Vinod, we just started the class. So this is about viral infections, the common one, and how to prevent it. So we just started with common cold. So we're mentioning about his clinical features. And people usually recover in 7 to 10 days, but sometimes the symptoms may last up to 3 weeks. And usually it is self-limiting, no need to take any much medicine. It is always told as a joke. If you are taking a medicine for cold, it will go off in 7 days. If you are not taking a medicine, it will go off in 1 week. So like that, a joke is being used to say in India. Prevention, there is no vaccine. And I always say you, whenever we say about the prevention in preventive medicine, the main thing, if it is infectious diseases, it is to mention about the vaccine. So there is no vaccine because because of the constant mutation of the viruses also involved. There is no vaccine. So what is the best way? It's to hand washing, use of face mask, and also if it is in the healthcare environment, gowns and disposable gloves are also used. Isolation and quarantine is not mentioned or it's not advised because the disease is so widespread and symptoms are non-specific. So this will be the upper respiratory tract. I mean only up to this part, the nasal cavity, the pharynx and the larynx. Below to the larynx, it is considered as the lower respiratory tract. And prevention is avoid contact with people. If you have flu-like symptoms, stay home until for 24 hours. Then constant hand washing. Avoid touching your eyes, nose and mouth as germs spread faster that way. Instead, cover your mouth and nose with a tissue when you cough or sneeze, and then throw the tissue away. The second one is smallpox, or otherwise called as variola. So this is caused by variola virus, and clinically, the symptoms will be fever, headache, backache, vomiting, and sometimes convulsions. This was more common in children. And on the third day of fever, a rash appears, which is centrifugal. Centrifugal appearance means the rashes will be more on the face and also on the extremities. On the body, it will be very less. So if you remember a smallpox patient, I mean, we have never seen a smallpox patient, but in some pictures or in movies, if any documentaries, you could remember a picture in which the smallpox person will be having that scabs or the rashes more in the face. So that is the centrifugal, where it is more appearing on the face and also the extremities, but not on the body area, not on the trunk. And it will be going through successive stages. Initially, there will be just a macule, a reddish discoloration, and then will be slightly raised, the papule, and then go into a water drop or dew drop like vesicle, and then to a pustula stage, and finally scab formation. So this is one of the thing where we need to differentiate with chickenpox. In chickenpox, when we see the person, the patient will be having uh, the all these varieties of skin changes or the rash changes at the same time. But in case of smallpox, it will be one stage by stage. So when you are seeing macule in a patient with smallpox, he will be having only macule. Then it will go to the next stage, papule, like that. There won't be all the rashes or all the type of rashes we cannot see in the same person in case of smallpox. So previously it was one of the greatest killer disease. In 1967, WHO began an intensified worldwide campaign to eradicate smallpox based on the technique of surveillance and containment. Uh, Even this can be asked as an MCQ. Okay, what were the techniques that were used by WHO to control the smallpox? So it was surveillance. Surveillance means it could be active or passive also. Active, they will be getting into the community and searching out the cases. And once they find out the case, isolate the person, containment. And along with that, the most important thing was vaccine. Malaysia successfully eradicated smallpox in 1978, a year ahead of the WHO declaring the world smallpox free. WHO declared it in 1979, but in MCQs, we always considered this one, the 1980 May, when the World Health Assembly confirmed the global eradication of smallpox. All countries since then have discontinued routine vaccination against smallpox. Then the chickenpox, which is varicella. Chickenpox or varicella, it's an acute, highly infectious disease caused by varicella zoster virus, and it is characterized by the appearance of that vesicular rash, which you know, for which Rustox is a very good medicine, or we say it as a dewdrop appearance. So, agent is varicella zoster virus is also called as human or alpha herpes virus 3, could be asked as a MCQ. Source of infection, usually a case of chickenpox. Case means a patient with chickenpox. That is usually the source of infection. The virus occur in the oropharyngeal secretions and also lesions of skin and mucosa. The chickenpox patient will be having some nasal symptoms and also throat symptoms. So in his oropharyngeal secretions, when he is coughing, sneezing, the virus will be spread out. And also on the lesions, the rashes he is having, the vesicle, the papule, inside that also we could get the virus. So that are the source of infection. And in the host factors, age, usually this is seen in children under 10 years of age. Immunity, one attack gives durable immunity. Second attacks are very rare, and if at all it is happening, it will be usually herpes zoster. Environmental factors, chickenpox always shows a seasonal trend, which means in winter and spring. And if it is, sorry, and if it is a tropic country, it will be usually in the coolest and driest month. So transmission, because it is present in the oropharyngeal secretion, as I told already, it will be transferred from one person to person via droplet infection and also by droplet nuclei. Do anyone know what is the difference between droplet infection and droplet nuclei? Anyone would like to make a guess? Actually, we have told this in some of the module. I don't know, even maybe practice of medicine. Okay, when the person is coughing, coughing or talking or sneezing, at that time the droplets will be coming out. And if it is larger in size, and they have put a measurement like 5 micro size, so if that droplet is more than 5 micron size, then we call it as droplet itself. But droplet nuclei always indicate something very small. So if the droplet size is less than 5 micro, then it is called as a droplet nuclei. So in case of chickenpox, it can be transmitted by both droplet infection and also droplet nuclei. And why we specify like this is droplet nuclei, because it is less size, it will be present in that area where the patient was there, or that environment for a longer time. But in case of droplet, so even if another person is coming to this environment where the patient was there and the droplet nuclei is there are chances that he get infected, because the droplet nuclei being very smaller in size, it will tend to remain in the environment for a longer time. But if it is droplet, usually because of the heavy weight, it will be getting settled somewhere, like it will be falling down to the floor. Nevertheless, the patient comes, and if it is in some of the things that has been, now we are sitting over here, and if I'm coughing and I'm having even if it is a droplet, it may be getting stick to the things surrounding in this area, maybe the CPU, the table, anywhere. And if a person is coming after some time, and if he's touching there and accidentally his hand is being going towards the uh, this one nasal, or the mostly nasal or the mouth region also, then also the infection can develop. So that is why they specifically mention droplet infection and droplet nuclei, because the time constraint doesn't affect here. Even if it is droplet, the higher bigger size, or the nuclei, it will be standing for long, so we need to be very careful. Or it also means that it is rapidly spreading, easily transmissible from one person to another. Most patients are infected by face to face or personal contact. Portal of entry is upper respiratory tract or the conjunctiva. And clinical features, there is pre-eruptive stage and an eruptive stage. In pre-eruptive stage, before to the appearance of rash, the onset is always sudden with a mild or moderate fever. Sometimes even the fever will not be there, it will be very mild. Sometimes patient may be saying only about a malaise or a tiredness, but backache may be there. Backache is very characteristic, and also shivering. The stage is very brief, lasting about 24 hours only. And then, when the fever starts, on that same day, the rash appears. So, that when the rash started appearing, we call it as an eruptive stage. The rashes will be symmetrical. Symmetrical in the sense, if it is present on the right hand, then a similar one will be present on the left hand also. It first appears on the trunk, or on the trunk it will be very abundant, and then on the extremities, and on extremities it is less abundant, and such an appearance we call it as centripetal. So that is the second difference between smallpox and the chickenpox. uh, the thing is, in case of chickenpox, it will be more centripetal, like the rashes will be more seen on the body part, the trunk region, and very less on the face and also the extremities. Whereas in smallpox, it is vice versa, where the more rashes will be found on the face and also the also on the extremities, but very less on the trunk region. So, smallpox will be centrifugal and chickenpox will be centripetal in appearance. The rash advances quickly through the different stages of macule, papule, vesicle, and scab. And another feature is pleomorphism. Pleomorphism means all these changes we could see in the same patient simultaneously. Whereas in case of smallpox, we see each case progressively only, not together. So these are the difference between smallpox and chickenpox. You see the patient, how the appearance will be. So in case of smallpox, incubation is 12 days or 7 to 17, and chickenpox it is 15 days or 7 to 21 days. The prodromal symptoms or the initial symptoms, whether fever, malaise, tiredness, all those symptoms, that is the prodromal. In case of smallpox, it is very severe, and chickenpox it is mild. Distribution of rash, I already told, in smallpox it is centrifugal. So mostly on the face, palms and soles will be involved, but not the axilla, and mostly on the extensor surface. And everything is opposite in case of chickenpox. The centrifugal will become centripetal over here. Palms and soles are not involved. Axilla is affected, and it is more on the flexor surface. The rashes in case of smallpox will be deep seated. That is why in the pictures we could see a person who had smallpox and survived. They will be having that scab mark on their body. The disfigurement will be very prominent. But in case of chickenpox, most of the rashes will disappear within a few months. May it take 1 year or 2 years, but then ultimately that also will go. So the rashes, in case of smallpox, it will be deep-seated, but in chickenpox, more of superficial. It will be multilocular and umbilicated. That means there will be in the rash, if we see the vesicular stage mainly, there will be a pinpoint over the a depression over the and just different multiple points also will be present. That's why it is called multilocular. But in case of chickenpox, it will be unilocular, more like a dewdrop. This is one stage at a time, but over here in chickenpox, it will be pleomorphic. All the stages, or 2 or 3 stages, we could see together. There is no inflammation around the vesicles in smallpox, but in chickenpox, there will be inflammatory signs seen around the vesicles. Now, how about the control and prevention? The usual control measure are notifications. Especially, we are supposed to notify the certain diseases that we have seen. It varies from countries to country, but most of the countries would be having this chickenpox to be notified because it is rapidly transmissible. Then isolation of the patient for about 6 days after onset of the rash, because during those 6 days, when the rashes are going through its different stages until the scab formation, and it falls off from the body, the patient can actually transmit the disease to another person. So isolation is very essential, and also disinfection of all the things that is being used by him. Prevention, there is actually vaccine, and also there is the immunoglobulin, which means one will be the vaccine will be giving the active immunity, where we are going to introduce the antigens, and the person's immune system will be producing antibody against it. But the one that we commonly use is immunoglobulin, which means we are going to inject antibodies directly to his body. So usually if we are going to give immunoglobulin, it means it is after to the exposure, giving the passive immunity. The immune system of the person exposed, he doesn't have to produce the antibody, not like that. So if you are exposed, if a person is sometimes getting exposed to a chickenpox patient, then he can immediately go and take this varicella zoster immunoglobulin, and it should be given within 72 hours of exposure, um, and has been recommended for prevention of chickenpox in exposed persons, especially those who are immunosuppressed. And vaccine, there is a live attenuated vaccine, and it is recommended for children between 12 to 18 months of age, like 1 to 1.5 years, who have not had chickenpox. Combination vaccines, because we can give it like in a combination with MMR vaccine. MMR vaccine is for measles, mumps, and rubella. So we can combine that vaccine, that is the combination vaccine, and can be administered between 9 months to 12 years of age. However, this is not coming under the national immunization schedule. This is not a mandatory vaccine as suggested by the government, not in Malaysia and not in India also. So, though there is a vaccine, it is not generally advised to take this vaccine separately. Maybe nowadays, I don't know whether it is given as a MMRV. I'm not sure about it nowadays, but usually it is not given individually. The duration of immunity is not known, but is probably 10 years. The next condition is measles, or the other name is called as rubeola. So rubella because it produces the reddish appearance. And here the rashes will be more like morbilliform rashes, or what we say is like sand that has been thrown on the body. So if you can imagine like the beach sand, if it is thrown on someone's body, how it will be appearing. And the same size, if it is reddish in appearance, then the patient is having measles. But when I say you this, I should also say that nowadays I see a varied appearance, because when I was a BHMS student, I could very easily differentiate the chickenpox from measles, just the rash itself, if I was seeing in the initial stage also. But nowadays I have to wait, because maybe the disease presentation is also changing, the rash appearance is also so much changing, that we had to wait to confirm whether it is chickenpox or measles. That much the appearance have changed. So anyways, this is the simile that we usually say, like the sand, red sand that is thrown on a human body, that will be the rashes of measles or morbilliform rashes. So measles is acute, highly infectious disease which is caused by RNA paramyxovirus. It is characterized by fever and catarrhal symptoms. Catarrhal symptoms is very big characteristic of measles. The patient will be having the nasal, the throat symptoms, and also the eye symptoms, very much characteristic in case of measles. And that is one differentiating feature also from chickenpox. The smallpox now it is not the it is terminated from. So we don't have to study much into the smallpox. Only to differentiate the difference between smallpox and chickenpox, we just study that. But chickenpox and measles, that is very important to know. And one of the important feature by which we differentiate chickenpox and measles will be the presence of the catarrhal symptoms, the eye, the throat symptoms, especially the eye. that is highly characteristic in case of measles. So if there is a lot of ophthalmia and conjunctivitis or reddishness, even on the conjunctiva, the patient will be having the sand-like sensation, then lacrimation. Then it is more the patient is having measles, and it could be confirmed with the red rash, high fever, and also cough. Because all these features chickenpox wouldn't be having. Even in chickenpox, the fever, if the it will be, as we told, it will be mild and moderate. But in measles, it will be very high temperature. So measles occur only in human beings. There is no animal reservoir of infection. Whenever we say there is no animal reservoir, it means it is sometimes giving a clue that if this disease is seen only in human beings, we have more chances of even terminating this disease as like that of smallpox, provided we control the cases or the carriers. So that is the indication, because here there is no other organism or animal that is in between, so we don't have to control them, kill them, nothing. If we are sure that this disease is seen only in human beings, transmitted from human beings to human beings, then our controlling the prevention mechanism, everything can be targeted only towards the human beings. And in human beings, if we can control, means we can actually terminate the disease also. So that is why whenever we say no animal reservoir, we need to keep this point in the mind. One attack of measles generally confers lifelong immunity. Infants are protected by maternal antibodies for up to 6 months. So, when a baby is born, up to 6 months, maternal antibody will be protecting the baby from the measles. And but after to that, the antibody won't be there. That is why the vaccination is usually for measles given around the 9 months. Host factors age usually seen between 6 months and 3 years of age, because before to 6 months, mother's antibody will be protecting the baby. Transmission is occurring from person to person mainly by droplet infection and droplet nuclei, like that of chickenpox. It is highly infectious during the prodromal period and at the time of eruption. So this is a risky thing, because the prodromal period, when the patient is having high fever, lacrimation itself, or even before the appearance of the eruption, the patient is highly transmitting the able to transmit the disease. Incubation period is 10 to 12 days from exposure to that prodromal period stage, and 14 days from exposure to rash. So you need to remember these days in case of these diseases in OM3, as I told you. You don't have to study much into the pathophysiology, but here you will be learning about the communicability, the incubation period, because it is that time, or the communicability time, where we have to get into, or the public health professionals, the preventive people, they have to get into. So we need to know what is the communicability period, when the person can transmit the disease to other, until when he should be isolated, until when he should be quarantined. All these things comes depending on these days. So over here in this PPTs, or in this subject, or M3, the PSM, you need to give more stress upon those days. So incubation period 10 to 12 days from exposure to prodrome. The patient got exposed to the virus, and then the prodromal period starting with the fever and that ophthalmic symptoms, that takes around 10 to 12 days, and 14 days, like in the range of 7 to 21 days from exposure to rash onset. So you can see initially the exposure happens, and then after about 10 to 12 days, the prodromal symptom starts. But the rash is appearing on some other day, usually on the fourth or fifth day. That is why this is also called as fifth day fever. So that is why the gap is there is a gap between the prodromal period and also the rash onset. In case of chickenpox, when the patient started the fever is mild, but that day itself the eruption started. But in case of measles, the fever will be there, and it's only usually fourth or fifth day the rash will be appearing. The period of communicability is 4 days before and 4 days after the appearance of the rash. Portal of entry, like chickenpox, it is the respiratory tract and conjunctiva. Here also we have the prodromal or the eruptive stage, and a post-measles stage. So prodromal stage, it begins 10 days after to the infection and lasts until the 14th day. And why they say until 14th day? Because from 14th day, the eruption is appearing. So then it goes into the eruptive stage. And the prodromal stage that will be characterized by fever, coryza with sneezing, cough, redness of the eye, lacrimation, and often photophobia. Pathognomonic feature will be Koplik spots. It can be asked as a MCQ, and it usually appears on the buccal mucosa opposite the first and second lower molars. In the eruptive stage, that is on the 14th day when the eruption started appearing, it will be dusky red maculopapular rash. It is never going to go into a vesicular stage or a pustular stage as like chickenpox. It will be just maculopapular rashes. It usually begins behind the ear and spread rapidly in a few hours over the face and neck and extend down the body to feet, taking 2 to 3 days. And post measles stage, the patient or the child will be losing weight. There can be diarrhea, cancrum oris. Cancrum oris means it will be a very uh, fatal condition, a gangrenous condition of this the oral and the nearby to oral structures. And that is because when the measles come, and if you are not going to give proper care to the patient, the child may have co-infections also, like his immunity will be affected that much. So even other bacteria or other viruses can infect him very easily because the immunity of the patient will be much lowered. So at that time, if the proper care was not given, the patient can develop cancrum oris, pyogenic infection, the streptococci, staphylococci. All those bacteria, viruses can cause infection. So cancrum oris will be like a gangrenous destruction can happen, and usually caused by, and even resulting in necrosis, can be caused by bacteria and viruses. There can be fungal infection, that is the candidosis, and reactivation of pulmonary tuberculosis. In case of tuberculosis, we know sometimes the gonorrhea will be formed in case the immunity is very strong. And if you remember, I mean, in next chapter 11, I think we'll be studying about tuberculosis once again. But there also, I'm not going much detail into about the tuberculosis, but can make you remember. You might be remembering the tuberculosis when the Mycobacterium tuberculosis, the bacteria enters. If the person's immunity is very strong, it will be forming a, it will be enclosed into a structure or a tubercle, and we call it as a Gons focus. And we say sometimes the patient will die with that Gons focus. It will never be getting reactivated. But if there's some condition happens where the immunity of the patient is lowered, example AIDS or any condition, even measles. So in those conditions, if this baby was having TB and baby or child, and it was at that time the immunity was very strong and the Gons focus was formed, the patient never developed TB. But after the measles appeared in him, and if proper care was not given, regarding the food, the nourishment, etc., not just medicine, but the nourishment, etc., proper water or the rehydration therapy, if you don't give that much care, the immunity will be much affected. So even that reactivation of the tuberculosis can happen. So measles, as such, it is not causing much trouble when we compare to that of a chickenpox. If you consider chickenpox, the person will be having much pain, irritation. He will be having the tendency to itch, and then the vesicles will be opening up, the pus. It is, and sometimes it may be even formed in case of chickenpox, the eruptions inside the mouth, the anal region, the mucosal structures also. So even eating, drinking, everything could be troublesome for the patient. But once the rash has gone, chickenpox rarely, I mean, it also can lead to complication. One of the complication will be raised syndrome. But usually it is self-limiting, and for most of the patients, there won't be much complication. But not in case of measles, because the immunity is much getting lowered over here. The patient will be subjected to a lot many complications. So that is why in case of measles, the vaccination becomes important. As I told you, in chickenpox, though the vaccine is there, it is not kept as a mandatory. But measles vaccine, be that in Malaysia or in India, the measles vaccine is mandatory. Every the ninth month, the baby will be given MMR. So vaccine, it is the live attenuated vaccine that is recommended for usage and usually given at 9 months of age. The vaccine develops immunity 11 to 12 days after vaccination and usually it is of lifelong duration. You can give it as a combined vaccine, the MMR vaccine, which is the measles, mumps, and rubella, uh, and also can be as like earlier MMRV, that is measles, mumps, rubella, and also the chickenpox one, MMRV, and only measles and rubella, that is MR, can also be given. And eradication, measles, because we told that there is no animal reservoir, it is amenable to eradication because you give vaccine and the vaccine is providing immunity for lifetime, which means as like smallpox. In case of smallpox, though we told the reasons, containment, surveillance, etc., but along with that, the most important thing was a very effective vaccination against smallpox. So, like that, in case of measles, also, this is highly effective, giving lifelong duration or lifelong immunity. So, only one dose of MMR is required to eradicate this disease. But, but the thing is, to achieve that eradication, like that of smallpox, we need the immunization coverage of at least 96% of children under 1 year of age. And in most of the developing countries, that is not the situation. It has not reached 96%. Even in India, I think Malaysia would be better. Even in India, it is around 80, 85 percentage, the coverages. And if there is an outbreak of measles, it should be ideally, the person should be ideally isolated for 7 days after the onset of rash. And if the person is getting into contact with someone, those contacts should be immunized within 2 days of exposure. Prompt immunization at the beginning of an epidemic is essential to limit the spread. The next condition is poliomyelitis. So, in the pre vaccination era, poliomyelitis was found in all the countries of the world, but now, because of this vaccine, the extensive use of polio vaccines since 1954, it eliminated the disease. Now, only three countries report polio cases, that is Afghanistan, Pakistan, and Nigeria. Now there is two program, that is polio eradication and end game strategic plan. This was functioning to eradicate poliomyelitis. This is one of the disease that WHO has kept in the list to eradicate very soon. So in that plan, they had this program, polio eradication and end game strategic plan, which was running from 2013 to 2018, and it was developed by GPEI, or Global Polio Eradication Initiative. It is the first plan to eradicate all type of polio disease simultaneously, both due to wild poliovirus and due to vaccine-derived poliovirus. I'll explain you this sentence a little bit later. So, the wild poliovirus type 2 and 3 were declared eradicated in 2015 and 2019 by WHO, the Southeast Asia region. Sorry. The wild poliovirus type 2 and 3, it was declared eradicated in 2015 and 2019. WHO, the Southeast Asian region, that means including India and also Malaysia, it was declared free of poliovirus in 2014. And most recently, in the WHO African region was certified free of wild polio virus in August 2020. However, the final step towards eradication have proven the most difficult. So here you can see the Southeast Asian region. It was declared of poliovirus in 2014 itself. And in case of Africa, It is declared free in 2020. But then we see that cases are seen also in Nigeria. We'll go to that why it is happening, because everything is connected with this sentence. It is the first plan to delete, I mean not delete, to terminate wild polio virus and vaccine derived polio virus. We need to explain that. We'll see that. So anyway, and now after to this 2013-2018 program, now the polio eradication strategy 2022 to 2026 is running, and that's also done by the GPEI. So I just kept a timeline of their plan in 2013 to 2019, the objectives 2019 to 23, and now the goals, just for your knowledge. So in case of polio, the agent, it is actually the polio virus. There are three types of polio virus, 1, 2, and 3. And most of the paralytic polio are due to type 1 virus. So that is, now we can go to the previous one where it says that the wild polio virus 2 and 3 have been terminated. And that has been declared eradicated, but still the type 1 is existing in some of the countries. The route of transmission is usually fecal oral or droplet infection, because the polio patient either via when he is having that coughing, sneezing, etc. It can be transmitted by droplet infection. And also this virus will be multiplying in the intestine, the stomach region, or the GIT, and then it will be shed via the stool. So if the via I mean if the stool is not properly disposed, then the disease can be spread by fecal oral route also, because the infectious material or the virus is present in case of the patient in the feces and also oropharyngeal secretion. Man is the only known reservoir of infection. Most infections are subclinical. Period of communicability 7 to 10 days before and after to the onset of symptoms, which means ideally we should isolate the person this much time. Children are more susceptible, and risk factors, especially if those children we are doing a tonsillectomy during the epidemic of polio, then they have a risk factor. And if they are given alum containing vaccine, the DPT vaccine, then also it can result in a polio. And incubation period is very short, 7 to 14 days. Now, clinical spectrum, actually there are four varieties, or the spectrum, we could say the four, not four varieties, but like a spectrum, like four types of clinical presentations might be the. The first one is inapparent or subclinical. So you understand from that term itself, subclinical means the symptoms won't be there. So 91 to 96 percentage of polio virus infections, they don't have any presenting symptom. So they are the subclinical infection, and that itself is a danger, because they are not going to show any symptoms. And if they are not going to show any symptoms, we are not going to isolate those persons. But those persons, they can transmit the organism when they are coughing or sneezing via their droplet and also by feces. And that is why, even though there is only a man as the reservoir, it is very difficult to, I mean, not that difficult. They are trying to, and mostly it is being declared free. But the thing, it could even be completely declared free or eradicated, because most of the cases, 91 to 96 percentage of infection, they are subclinical. They don't show any symptoms. So the best way to prevent this disease is to give the polio vaccine. Then 4 to 8 percentage, they can have abortive polio, a minor polio illness, and that will be very mild or self-limiting illness. Then there can be non-paralytic polio. In about 1 percentage of all infection, the presenting features will be stiffness and pain in the neck and back. There can be paralytic polio, which is occurring in less than 1 percentage of infection. So among the people who are infected with the polio virus, less than 1 percentage will be having paralytic polio. And here the virus actually enters. Usually it is the GIT symptoms that is very commonly seen, but here the virus will be invading the CNS and produces flaccid paralysis, asymmetrical flaccid paralysis. So if it may be only one limb that is affected, it's not that if you have seen polio patients, it will be usually one limb. It is not symmetrical. If it is not, if the left limb is paralyzed, then right also will be affected. Not like that. Usually it will be one limb that is going towards a paralytic stage. Other symptoms will be malaise, anorexia, nausea, vomiting, headache, sore throat, constipation, and abdominal pain. And prevention will be two type of vaccine: the inactivated polio vaccine, and also which is also called as vaccine, and oral polio vaccine, which is also called as Sabine vaccine. So there is the difference between IPV and OPV also. In IPV, which is injected actually, it is the killed vaccine, but OPV vaccine, it is the live attenuated virus. And live attenuated, I told you the virus will be alive, but it will be very weak actually. IPV, it is given as an injection subcutaneously or intramuscular, but OPV usually given as a drop via the mouth. Now, this is one of the difference. In case of IPV, uh, now I'll say what is this vaccine and wild type of polio virus. So here you can see this OPV. Yeah, actually, this OPV, they were using vaccines 1, 2, and 3. We'll come over here. So, in the difference, the IPV and the OPV vaccines, the thing is actually OPV vaccine we can give to, I mean, administration is very easy. The strategy is usually the children under 5 years of age, one particular day of an year, they are given this oral dosage of polio vaccine. And that is very effective actually, this polio orally given polio vaccine. And why that is happening is when this oral polio vaccine is given, it produces antibody, both humoral and intestinal, and it induces that antibody production very quickly. But in case of IPV, it is producing only circulating antibody, but no local antibody or the intestinal antibody, which means that when we are giving this vaccine, suppose we are giving oral polio vaccine to the patient or a baby that is born, maybe 2 years, we are giving oral polio vaccine to that baby. This oral polio vaccine is highly effective that it will produce two type of antibodies. One, this vaccine is actually having antigen, that you know the vaccines are actually having antigen. So when it is going inside our body immune system will be producing antibody. So in case of antibody OPV, the antibody that will be produced, it will be circulating antibodies. That is why it is called as humoral, which will be seen in our serum or the blood. The antibodies will be seen. But this OPV will also it's also able to produce the IgA antibody, which will be coating over the mucosal surface of the stomach. Now, which means that if you just go back to your immunity chapter, if you remember, over there I have told to you in case of IgA is such an antibody. You know, there is IgG, IgA, M, E, and D. Out of that, IgA has got a special feature that this IgA antibody is actually seen on our all the mucosal surface, even on the nasal mucosal the area, the oral area, the conjunctiva. All this will be having a layer of IgA protected. So that in IgA is also seen in the blood also, the circulating one. Other than that, locally it can be seen in wherever there is a mucosal layer. And that immunity, we call it as a local immunity because that IgA is not circulating in the blood. It is seen in that mucosal surface area. So that local immunity will be there. And that IgA, we usually consider it as a part of natural immunity because everyone, on all the people who are not that immunocompromised, they will be having a good layer of IgA on their mucosal layer. So only most of the infection, because we are exposed to a lot of bacteria and viruses, we are not getting that infection very easily because of this IgA protection on the mucosal surface. So now we are applying the same principle in case of OPV. When OPV is given, it produces both the type of antibody, the humoral antibody, that is the circulating one, and also it will increase the antibody, the IgA, and that is also seen, this IgA will be seen coating the mucosal layer of the stomach or the intestine. You know that stomach, intestine, everything is having a mucosal layer. And I told you in case of polio, mostly it will be the GIT symptoms because there is the bacteria, sorry, the virus will be multiplying in the GIT and it will be shedded off via the stool. So, in this case, when a patient is having, and most of the patients will be having intestinal, it is less than 1%, persons will be having the CNS symptoms. And that is because from the GIT, they are entering, the virus is entering into the blood and going towards the CNS and causing the paralytic symptoms. Otherwise, it is just confined with the GIT symptoms. So when OPV is given, the OPV, because it is live attenuated vaccine, it is also able to generate that local antibody, the local IgA. So even the mucosal layer of that esophagus, stomach, intestine, everything will be having that thick IgA coating. So what is the benefit is, now when this person, the vaccinated person, if he is exposed to polio virus in future, just imagine if he is getting infected with that, because initially the virus is not going to go towards his blood, it will be usually getting into his GIT. So because the IgA is very strong over the polio vaccine, OPV has already provided the local immunity. The viruses will not be getting multiplied in the intestinal area because the antibodies are there, and that antibodies will be killing all those viruses. So the viruses will not be shed via the stool. And even if it is shed, it will be the dead virus, which can't be infectious. So that will not be happening. And because the viruses are getting killed in the intestine itself, it is not going towards the serum or to the CNS. So even the paralysis is not going to develop. So OPV in that manner is very helpful. So even if the baby is getting infected in the later life, it's not going to develop the GIT symptoms of the polio or even the CNS symptoms. But now what happens in case of IPV, because it is the killed vaccine or the killed virus is used, they are able to produce only the serum antibodies or the humoral immunity, not that local immunity. So what happens in this person is, if we are giving only IPV, what happens is the same person, we didn't give any OPV, only IPV when the baby was born. I think IPV 3 doses has to be given. I don't know the exact timing. I don't remember now. Anyway, 3 doses have to be given. So only that was given. OPV was not given. So what happens is, when this child is getting exposed to the polio virus later in the life, because he doesn't have that local immunity, the virus which entered, it will be getting multiplied in the intestine, and he may have the GIT polio symptoms. And this virus, because it is getting multiplied, it will be shed via the stool also. And if the person is shedding the virus or the infectious material via the stool, you know it's danger. If that stool is not properly disposed, it is resulting, because there is a fecal oral transmission. So this child who got infected and had received only IPV, they are going to shed the virus via the feces, which means they are able to transmit the disease to the community. And also, uh, So that is a risk, because if we are not giving OPV to the child, that child, if ever getting infected with the polio virus, the virus will be shedded via the stool. And if the stool is getting somewhere exposed, then the person is a threat to the community, because there is a community transmission of virus that is possible over here. So in that manner, when we see, OPV is very ideal, because the patient will be protected. He is not affected because he is having the humoral immunity. And because of the local immunity, the viruses is not getting developed in the intestine and not going via, or not excreted via feces. So even the community is protected. But that protection is not happening in case of IPV. So now we feel, okay, then only OPV is enough. Why to give IPV? But the thing is, when we go for this one, the IPV, it doesn't require stringent condition during storage and transportation, whereas OPV, the cold chain is very much important over there. They have to be stored and transported at sub-zero temperatures. And then this is having a longer shelf life also. So some benefits are there with IPV and some benefits are with OPV. Um, in this IPV, because it is producing circulating antibody, it can prevent paralysis, because the virus, when it enters into the serum, obviously there is antibodies against those virus. So this paralysis will be prevented. But still, because there is no local infection, if again the patient is getting exposed to the polio virus, they will be having reinfection, because there is no local immunity, or the intestinal immunity is not provided. But in case of OPV, it prevents both the paralysis, because there is humoral immunity or humoral antibody. And because of that local antibody in the intestine, there is no chances of intestinal reinfection also. Because even if the virus is coming, it is not going to get infected. The antibody present over there, it will be killing that viruses. But this IPV, uh, this is not useful in controlling epidemics. And now you can say, what is the reason? Because as I told you, in case of IPV, because there is no local immunity, this child will be excreting that virus into the via the feces, which is a community threat. So that can result in an epidemic. So if in case polio is ever coming as an epidemic, and only if we are going to give IPV, the patient will be protected. The patient, because there is no paralysis that is going to develop in him, that will be protected, but never the community will be protected. That is the meaning. IPV can't control the epidemics, whereas OPV can control. It can control, help the individual, because paralysis is not going to develop, and also because it won't be shed via the feces, even it is good in controlling the epidemics. But then the problem with OPV, the thing is, the OPV, actually they used type 1, type 2, and type 3 viruses to produce this. But later it began, they started witnessing that some of the people who take the polio vaccine, because the type 2 variety used in this OPV vaccine, it can mutate. And when it mutates, it can result in a polio in that person or in that child who had taken vaccine. So this is not a wild polio. That was this person or this child who developed the polio after taking the vaccine. They are actually having the vaccine derived polio. It is not the wild polio. It is not that the polio from outside environment entered his body and then he had a polio. No, it is not that wild polio. But he developed that polio because of the OPV he had taken, because the type 2 variety in OPV, it could mutate, and that can result in vaccine. And that is called as actually the vaccine derived polio virus. And because of that, OPV, the WHO always think of stopping the usage of OPV, because this OPV, though it seems to be very beneficial, it is resulting in vaccine derived polio. So they wanted to stop it, but they couldn't stop. one thing, because the IPV is not efficient. IPV is not efficient to control the epidemic because it is not giving local immunity. It is giving only the personal immunity, which is not enough. Or every person should be taking the polio vaccine, and that is not happening. Never any vaccine is going to have a 100% coverage. There will be always there will be very less. At least some people will be the who wouldn't be taking vaccines, and it can't be like made something very mandatory. It depends upon the person's choice also. So the thing is, though OPV seems to be very efficient, it is producing both the local immunity and the humoral immunity. Because of one strain over there, the type 2, it can produce in some persons, very less number of persons, but it can induce polio in them. So just imagine you are taking one vaccine, thinking that you are protecting yourself from a killing disease, not a killing disease, but a disabling disease. But then, just because you took that vaccine, you are developing that disabling disease. Imagine that situation. So now what WHO did was they are not able to stop the usage of OPV because IPV is not able to control the community spread or the epidemic. Until we get such a IPV, OPV can't be stopped. So what they did is they are eradicating or they are stopping the use of type 2 strain from that OPV to make it more safer because it is that type 2 that is uh, changing. So that is the difference between the wild polio and also the vaccine derived. So OPV, it can result in vaccine-induced poliomyelitis. However, the inactivated ones, IPV, are very safe. In a report in 2019, the World Health Organization noted that 9 new polio cases caused by the vaccine in Nigeria, Congo, Central African Republic, and Angola. So remember the earlier slide, we told that in 2020 they were declared free. They were declared free, but of the wild polio virus. WHO African region certified free of wild polio virus, which means in those countries, when we say Nigeria, which is also an African country, in those countries now what the polio is existing is actually the vaccine derived. But when we go for the Southeast Asian, you can say it is declared of free of polio virus. That means wild and also vaccine derived is not seen. But in Nigeria, there is a wild polio virus has gone, but not the vaccine. It is still present in Nigeria. But the wild variety and yeah, this one, Afghanistan and Pakistan is still having the wild variety. Nigeria is mainly now having vaccine derived. Of the two countries where polio remains endemic, Afghanistan and Pakistan, vaccine linked cases have been identified in Pakistan also. But nevertheless, they are having wild cases also. So the reason that I told you what happens with OPV is the live virus in oral polio vaccine can mutate into a form capable of sparking new outbreaks. And it have been found out that it is the type 2 virus which is present in the vaccine results in that. So WHO can't remove OPV because of the benefit it is giving, both the local and the humoral immunity. So they can't stop giving OPV unless IPV is getting that efficient. So what the WHO has done in 2016 is to switch from the trivalent polio vaccine that is using OPV type 1, 2, 3. That is because 3 are used, it is trivalent polio vaccine. So from 2016, they stopped it and they started using bivalent polio vaccine that is type 1 and 2. And the vaccine no longer contains type 2 polio virus. So that is what they have started doing from 2016. But the people who have had vaccine before to that, they might be still having the vaccine derived cases. I'm going towards the infective hepatitis. So viral hepatitis, it is an infection that causes liver inflammation and damage. Several different viruses causes hepatitis, including hepatitis A, B, C, D, and E. Hepatitis A and E is usually food related And those, contaminated food and water are the main reasons, not exclusive reasons, but the main reasons will be contaminated food and water for the spread of hepatitis A and C, A and E, and the middle ones, B, C, D. It is usually due to parenteral sexual transmission, etc. So A and E usually they cause acute infection, and B, C, D they causes acute and also chronic infections. So starting with hepatitis A, it is also called as infectious hepatitis or epidemic jaundice. That was the earlier name, and it is caused by the hepatitis A virus belonging to Picornaviridae family. Though here we say hepatitis A, B, C, D, E, and it is very easy to memorize. Mostly for the MCQ, they would be asking you the family to which it is belonging. And all of it, A, B, C, D, E, all of it belongs to different families. So you need to remember the name. So HAV, hepatitis A virus, it belongs to the Picornaviridae family. The disease will be characterized by fever, chill, headache, fatigue, weakness, aching, and pain. And then it will be followed once it reaches the GIT, the liver symptoms. There will be anorexia, nausea, vomiting, dark urine, and also jaundice signs. Reservoir, the human cases are the only reservoir of infection. And infective material, it is mainly the man's feces because in case of hepatitis A and E, it is fecal-oral route or contaminated food and water. So the viruses are actually shed via the stool. Blood, serum, and other fluids are also infective during that brief stage of viremia. So mostly the mode of transmission is fecal-oral route, parenteral via injections, and also via injections or even the blood transfusion, and also sexual transmission. Virus excretion. So in case of hepatitis A, the fecal oral route is most commonly seen. Nevertheless, the parenteral and also sexual transmission are also reasons. Virus excretion, HAV, is excreted in the feces for about 2 weeks before the onset of jaundice and for up to 2 weeks thereafter. So when it says before the onset of jaundice, 2 weeks before. So you understand, even when before we understand that the patient is having hepatitis, he has the capability of spreading the disease. So yeah, and also for 2 weeks thereafter. So we after once the jaundice appear, okay, we get cautious. This after 2 weeks later, we could isolate the patient and prevent the transmission. But the transmission that is happening before to the development of jaundice, because it is mostly inconspicuous symptoms, fever, chill, headache, the symptom of any viral disease. So it is not able, we are not able to differentiate. So this 2 weeks before the onset of jaundice, the patient can does have the ability to transmit the disease. So how to prevent it? We can go in 3 steps, like control of the reservoir, which is the man. It is difficult because of the reason that I told you. The fecal shedding of the virus, it is high during the incubation period when the person is not at all showing any symptoms in early phase of illness. So we can't control. We don't know the patient is infected even. So how we can isolate him? So that is one. Even though there is only one reservoir man, it is not possible. The occurrence of large number of some clinical cases. So most of the patient may not have any symptoms. Absence of any specific treatment and low socio-economic profile of the population usually involved. So the control among the reservoir or the termination is not possible because of these reasons. Then how we can control the transmission is the best means is by maintaining a personal and also community hygiene, because the main reason is fecal-oral route transmission. So maintain personal and community hygiene. But in case of susceptible population, that is the people, especially travelers who are going to highly endemic areas, those requiring lifelong treatment with blood products, because it is parental transmission also possible, men having sex with men, workers, because the sexual transmission, mostly homosexual, and workers in contact with non-human primates, and also injection drug users, those susceptible population, it is advised for them to take a hepatitis A vaccine. Usually, people, I don't know, in case of yours, your immunity, yeah, it also matters. But I know when people are coming from US, UK, who are not much exposed to these infectious diseases, when they travel to India, those travelers are advised always to take hepatitis A vaccine and also typhoid vaccine because the water that uh, we get in India, people in India are already immunized against it, but not the outsiders. But when I say immunized against it, that natural immunity, even when I leave my state and go somewhere, in Kerala, okay, I do have the um, yeah courage to drink water, but ideally, yeah, mostly. But if I'm crossing the border and going to some other state, I wouldn't go and have water which is not warm in hotels, in restaurants, never will be drinking. Will be always going for bottled water. Otherwise, even I'm an Indian. I just cross the border. Even I could have a diarrhea or any GIT infections very easily possible. So before you are going for your internship, you could take any preventive vaccine. If you don't want to take, it's fine. But always take care that you take only hot water and or the bottled water. And there is another thing in India. I don't know, have you visited? In India, the water is free in restaurants. Okay, you don't have to pay. Only if you are buying the bottled water, you have to pay. Otherwise, they give warm water. And it depends actually on that restaurant. If you feel that the things are comparatively neat, but still, I don't know about your immunity. But after some time maybe, but not on the initial days, not on the first few days. I wouldn't advise you to drink even the warm water from the restaurants. But that is anyway free. Over here, that we have to pay for the water also. No, no, we don't have that. So, both inactivated and live attenuated hepatitis A vaccines are available, and that gives protection generally long lasting, lifelong, in both cases of children and adults. But hepatitis A is also not mandatory, not in the national immunization schedule, but hepatitis B is. So, the second variety is hepatitis B. It was formerly called as serum hepatitis, causing major pathology in the liver and caused by hepatitis B virus. And this is a DNA virus. So among the hepatitis A, B, C, D, E, only the B virus is the DNA virus. All the others are RNA virus. And this was earlier called as, or it was originally called as Dane particle, and it belongs to the Hepatnaviridae family. So here you get the clue from the name itself, HEPA, which lead you to hepatitis or the liver, and then you get the clue from the DNA that it is a DNA variety. But only thing you have to remember is this hepatna is we are saying about the hepatitis B, and only hepatitis B virus is DNA. Among that A, B, C, D, E, all the other that is A, uh, C, D, E, all those are RNA virus. And in case of hepatitis B, it is usually the parenteral and sexual transmission. So the contaminated blood is the main source, but the body a virus can also enter via saliva, vaginal secretion, and semen. Age, the outcome, I mean, it can be infected at any age, but the outcome is actually age dependent. So we can see acute hepatitis can occur 1% perinatal around the time of delivery due to some infection that is happening. Infection means the not so hygienic manner of dealing with the blood and all. If that is happening, or from mother to child, this can happen 1% infection of HPV during perinatally, 10% in early childhood, that is from 1 to 5 years of age, and 30% in late years, that is more than 5 years. And but when we go for its chronic, because we have seen it is H and uh, hepatitis A and E, that is acute, B, C, D are chronic. So hepatitis B do have the ability to develop later into chronic hepatitis or even cirrhosis, and also even the liver cancer, hepatocellular cancer. Hepatitis B have that ability. So that is what we are mentioning, or what we indicate by saying outcome of HBV. So when we go for those chronic HBV infection, we can see it is inversely related. That is, only 1% is infected perinatally, but out of that 1%, 80 to 90% of people can develop into a chronic condition. So if a baby have had hepatitis B, like in around that perinatal period, then 80 to 90% chances are that the baby will be having chronic liver complaints. If it is in case of early childhood, it was 10% possibility of infection, and among that 10%, 30% can develop into a what is that, the chronic condition. But in adults, we see that hepatitis B is more commonly in adults, but the chances that adults develop chronic infection is very less. It is only less than or around 5%. So that is why the outcome of the HBV, that is the chronicity or the chronic complaints of HBV, it is inversely related to age. So 1% perinatally infected, but they have more chances of developing into chronic condition. 30% of adults are infected, but they have very less chances to develop into chronic hepatitis B. Most mode of transmission, that will be mostly parenteral route, perinatal from mother to their babies, and sexual transmission. There is hepatitis B vaccine. We have got the recombinant variety and also the immunoglobulin. So immunoglobulin usually given post exposure, like the person who got exposed somehow, like the surgeon, nurses, lab workers, when they are dealing with this blood and other serum related. Newborn infants of carrier mothers, sexual contacts of acute hepatitis B patients, patients who need protection against HIV, HBV after liver transplantation. All these people, we give them the immunoglobulin, the passive immunity, and it should be given as soon as possible after an accidental inoculation. If that exposure has happened within 6 hours, that is the ideal time, but not later than 48 hours. So if you're going to take HBIG after 48 hours also, it is not useful. It should be ideally taken within 6 hours. And these are the people who should be taking post to the exposure. Otherwise, we have the hepatitis B vaccine, which is ideally to be taken during birth along with BCG. Hepatitis B vaccine is available as monovalent formulation, or we can give it in a combination along with DPT, Haemophilus B influenza virus, hepatitis A virus, and also inactivated polio. When immunizing against HPV at birth, usually it is the monovalent vaccine that is given. So at birth, if it is given, it is monovalent, that is only HBV is given. But in combination, we can give in the later stage. And hepatitis B is mandatory in Malaysia uh, at the time of birth, along with BCG. Hepatitis C, this is caused by the hepatitis C virus belonging to the Hepacivirus genus within the Flaviviridae family. Here also the transmission is mainly occurring through blood or the parenteral transfusion. So blood transfusion, blood products, organ transplants, injections, uh, baby being born to hepatitis C infected mother, they all have the chances of developing hepatitis C. And you can remember hepatitis C will give to more chronic conditions. More than hepatitis B, hepatitis C leads to chronic hepatitis. So you can connect C to chronicity also. The signs and symptoms will be fever, fatigue, decreased appetite, nausea, vomiting, abdominal pain, dark urine, gray colored feces, joint pain, and also jaundice. Prevention, primary prevention, there is no vaccine for hepatitis C, so better we take careful. We should be avoiding unnecessary and unsafe injections, unsafe blood products, use of illicit drugs, sharing of that injection syringe, unprotected sex with hepatitis C, infected people, tattoos, piercings, acupuncture, everything we should be very careful when we are dealing with. Secondary and tertiary prevention, better to go with education and counseling so that when we are going for an unprotected sex or we are using a drug, I mean, not we, the people, the injection drug users, to give them awareness about all these things when the people go for tattoo, piercing, to take care of that. Immunization with the hepatitis A and B vaccine to prevent co-infection from this hepatitis virus to protect the liver. That is also told. We can't protect from hepatitis C, but once you know that the person is having hepatitis C, ideally take the vaccine for hepatitis A and B also. Because in hepatitis C, anyway, there are more chances for the patient to go towards liver damage, the chronic complaints and all. So to decrease its effect, ideally go for hepatitis A and B also. And there should be regular monitoring for early diagnosis and management. So this is in nutshell, hepatitis A, B, and C. A mostly by this one, fecal-oral route or the contaminated food and water and the direct contact. It may cause severe liver damage, but mostly acute. Hepatitis A vaccine is the hepatitis B, the parenteral mother-child transmission, injection drug users or due to the blood transfusion. Then that is going to cause liver cancer or liver cirrhosis. And there is hepatitis B vaccine also. In case of hepatitis C, the same transmission as like that of hepatitis B, the same route. It also can result in liver cancer and cirrhosis. And when compared to hepatitis B and C, as I told, hepatitis C is more going towards the chronic condition. And here it is no vaccine available. Then we have the hepatitis E, which is caused by the hepatitis E virus belonging to orthohepivirus of the Hepiviridae family. And that is essentially a waterborne disease. So mainly transmitted by fecal-oral route. Other route can be foodborne transmission, infected blood products, and also vertical transmission. So prevention, the symptoms will be almost similar to all the other jaundice that we have mentioned, the A variety. The risk of infection can be reduced by maintaining quality standard of public water because it is mainly a waterborne disease. And also because it is orophycal route, take care that we have proper disposal system to eliminate the waste. And ideally maintain hygiene, hand washing, especially before cooking, after coming from toilet, before eating, etc. Avoid drinking water and or ice of unknown purity. Lastly, the hepatitis D. It is found throughout the world across all ages. It can be received via multiple transfusion, intravenous drug abuses, and their close contact. But in case of hepatitis D, this is one thing that you have to remember. Hepatitis D cannot infect a person by its own. It doesn't have that ability because hepatitis D, when it enters into a person's body, for its multiplication, it need something like a envelope is required for its multiplication, and that envelope can be given by only HBV. So if a person is exposed to hepatitis D virus, mostly this hepatitis D virus cannot cause anything. It can, but this person is having already hepatitis B infection, then the hepatitis D also is going to show its action. Because for the multiplication of hepatitis D, they require an envelope which is provided by HBV, it's HBS antigen, they provide that envelope. So only if that envelope is present, HDV can multiply. Otherwise, it is not going to cause any infection. So we have to particular take care, not of HDV, but if a patient is diagnosed with HBV, we should be very careful that the person, we should educate the person that there are chances for him to develop HDV also. So HDV can be prevented by vaccinating HBV susceptible person with hepatitis B vaccine. However, vaccination does not protect hepatitis B carriers from superinfection. So in case we are giving a person who, when we give hepatitis B vaccine, in a way that person is protected from hepatitis D also, because D won't be infecting unless there is B. So if a child is given hepatitis B vaccine, which means the child is not going to develop hepatitis B. So in a way, the child is protected from hepatitis D also. But the patients who already had hepatitis B, they have chances, they have a bigger chance of later having this hepatitis D infection. And sometimes the hepatitis B, they may be carriers. They may not be showing any symptoms, but they may be shedding or they may be having these organisms present in their body. So even in them, they take the I mean, even if they take the vaccine, it won't be helping, because mostly they won't take the vaccine if it was not taken at birth. They may not be taking the vaccine. If the hepatitis B is already present in that person, HDV can get in and cause the infection. So in those people, the vaccine is not going to help. Next one is enteric fever or typhoid fever. Okay, we'll stop over here. Oh, I took only 30 slides. My God, how much is remaining? But only this one is bigger. The other one, it's only 35 slides. Yes, probably we'll finish on Monday. We took until hepatitis and helminthic enteric dysentery. Okay. Have you taken the screenshot?
Yes, already.